All right, so session 4, welcome everyone to the Luminal Advanced Gastroenterology session. We'll have our speakers come up to the stage here. We have Dr. Moon, Dr. Bilal, Dr. Davis, and Dr. Clem. And our first speaker will be Dr. Bilal. He's an interventional GI colleague to talk us about non-variceal bleeding.
All right. Thank you so much, Dr. DeLay, Dr. Kara, and Dr. Steiner for inviting me. This is definitely a premier flagship course for our division, and so exciting to see a lot of you all from both our colleagues that we work with, but also people that we closely collaborate with across the state of Colorado. So I'm going to talk about non-variceal upper GI bleeding. So I think when we talk about non-variceal upper GI bleeding, the first and foremost thing to think about is the Forrest classification. So when you see peptic ulcer disease or you see an ulcer and identify that on endoscopy, the most important thing is to recognize what is the risk of bleeding if you do not intervene on this ulcer or this lesion. So these things that are highlighted in red are area where endoscopic intervention is needed. Why? Because if you don't intervene, then the likelihood of rebleeding is extremely high. So obviously, if you see active bleeding, you have to treat oozing bleeding. If you see a non-bleeding visible vessel or an adherent clot, this is the risk of rebleeding, as you can see with a spurting or oozing bleed is almost 50 to 100% chance of rebleeding. So you might as well not do an endoscopy if you're not going to treat this. So once you figure out what you need to treat, then the next question is, how do you treat? And the way I think about GI bleeding is there's really two basic principles. First and foremost, you need to be able to see where the bleeding is coming from. So if you cannot see it, you can't treat it. So visualization is one, and the number two is what is available in our toolbox. So how do you improve visualization? So before the endoscopy, and I know that some of here are fellows in the room, and as well as residents are interested, is before you do endoscopy, you have to think about prokinetic therapy. So if you're worried about an active GI bleeding, you have to think about prokinetic therapy. So it's either erythromycin, 30 minutes before an endoscopy. So if I don't do it a lot of it overnight, but if I ever go in to do an overnight bleeder, while I'm driving in, I tell the fellow to call, make sure the erythromycin's there, and the nurses administered it. Not just ordered an Epic, but actually administered to the patient. And the next is the ability to be able to suction and identify if there is, how can you clear out blood clots? So we'll talk a little bit about it. ClearCap is really valuable, very cheap tool to add, which can help allow to look at the duodenal folds, especially in tough areas like the D1, D2 turn, allow that additional stability and then position change. And then the next thing is what's really in our toolbox to manage and treat GI bleeding. So the way I think about an non-variceal upper GI bleed, when you do an endoscopy, you got to look for four things, and then you can go into the nitty-gritty and do a proper exam. So is there bleeding in the GE junction? Are there varices, a malrevised tear? Within the GE junction is also where you see a dilophoid lesion, 6 centimeter close to the GE junction. The next is fundus. Is there gastric varices are present or not? Then you look at the antrum to make sure where the ulcers, and then the duodenal bulb where the big ulcers reside. A lot of times, I've been involved in cases where someone spent about 40 minutes trying to clear out fundus, blood, and then eventually go into the duodenum and there's a big ulcer with a visible vessel. So just do your big fours, go in, rule out these big fours, and then if you can't find anything, then you take your time, clean out the blood and the fundus and try to meticulously examine, take a look at everything. But that's how you quickly evaluate it. So when you talk about giving prokinetic therapy, it's not something that I prefer or like. This is what our guidelines tell us. Using erythromycin, sometimes it's not available. You can use Reglan, but the Reglan doesn't work as effectively as erythromycin because erythromycin works in the motilin receptors of the stomach, which helps the gastric motility and helps clean out the stomach. The next is what is in our toolbox for visualization. You're trying to remove, blood, snare, spend 2 hours in an endoscopy. So knowing and recognizing what are the tools that are available. So this is a BioVac, which actually system here on your left. Yes, on your left. And this helps look at and clear out blood clots. It bypasses the natural suction of the scope and allows you to connect this. You can really suction big clots. Then there's more novel therapies that, at our institution, we're hopefully trying to get soon. This is, as you can see, my cursor point, if you can, right here is a novel suction tube. It's like an overtube that can suction big clots and bypass all the suction. Because if you can't suction the clots, you're not going to be able to see where the bleeding is coming from. This is a device that we pioneered in my time when we were in Minnesota, which is over the scope cleaning device. Is really great for cleaning out bleeding, but it's also poor prep. You can suction and irrigate at the same time. Here's a case. For some reason it's not moving forward, so maybe I'll try from here. Okay, so here's a case. You can see there's a lot of bleeding after a gastric polypectomy, and because the blood will actively pool sometimes and limit your ability to see the bleeding, and you can see these clots accumulated quickly. So this device has a separate irrigation and suction jet. Here's in this publication that we published, you can see here we can suction and irrigate at the same time, and even these big clots you can clear out. And once you've cleared them out here, you'll see that we can identify the source of bleeding. And once we've localized it, then you can just put a regular hemostatic clip. So, the technique here was not the fact that you had to put a clip on the vessel that anyone can do, but it's really to know what's available in our toolbox so that we can improve our visualization. But sometimes these expensive or fancy tools are not available, or you may not be comfortable to use them. The most simplest tool that's available is changing the patient's position. So endoscopy position is the left lateral position. This is where we do upper endoscopy. And upper endoscopy, the blood will always pool in the proximal body and fundus. So if you have a bleeding source in the proximal body and fundus, it's going to be hard to visualize. But if you convert the patient to right lateral position, and all the nurses in the back have done that for me, and they hate me when I do that. But it does really make it easier to visualize this, because you can see here that now the blood pools in the antrum, and now you can easily see where the fundus bleeding is coming from. So simple, cheap intervention. I know it's annoying, frustrating to do sometimes, but can really help you in a difficult position. So this is difficult to do, and I really like this other position that's pioneered out of this publication in India, where they show, they call as a left lateral semi-recumbent position, a little bit easier to do this position. So again, you'll see the blood here pools in the fundus, and when you put them in the left lateral semi-recumbent position, the blood will actually start pooling in the gastric body. So here, you'll see how to make this position, normal stretcher, and you just really bring their head of the bed up 45 degrees. But it has to be that the patient's chest also has to be 45 degrees. So a lot of times when we put the head of the bed up, it's like a little bit of the neck that's up, but really not, the patient is not fully up. So you have to really pull them back, make their head up. And there are some examples here that you can see how if you put them in this position, how much your visualization changes and the blood moves. So if you forgot to give erythromycin or prokinetic, just changing the patient's position can sometimes be really valuable in trying to make sure that you can see the bleeding. So this is a lot of information, but let's put all of this together. So everybody who's done endoscopy, every nurse who's done endoscopies, remove this polyp, run-of-the-mill pedunculated polyp in the sigmoid. You put a hot snare around it, and once you put a snare around this polyp, all of a sudden you start having bleeding. So you see bleeding in this case, and it's hard to visualize where the blood is coming from. The patient's heart rate is going up, but my heart is going up even higher. This is obviously not my case. It's one of my colleagues who's had this, and it looks like a really difficult situation, So we're going to try to find our closest therapeutic endoscopist, just really to help our own anxiety. But you don't really need a therapeutic endoscopist in this case. This patient is in left lateral. All you need to do is switch the patient's position from a left lateral to right lateral position, right? So, and that may increase the heart rate of a lot of the team members, just knowing that we had to change the patient's position. But once you switch the patient's position to right lateral, what will happen is the blood starts pooling in a different orientation. And now all you see is clearly see blood coming out, right? All of a sudden, the situation that looked really catastrophic now looks like a simple bleeder. Use hemostatic forceps. Anyone who can do biopsy can use these forceps. You grab the vessel. You can see it's like a garden hose. The vessel's on it. You pull back a little, couple of taps and cautery, and boom, this disaster averted. No money added, no cost used, just changing the patient's position. A little annoyances from the team, but now you got an emergent situation controlled into a very controlled situation. So now, once you've put this together on how you can visualize the bleeding, the next step is to figure out what's in our toolkit in 2026 to try to manage this bleeding. So epinephrine injection, the oldest tool that we have. We never want to use epinephrine alone because it's only transient. It will only give you transient hemostasis and not durable hemostasis. So once in a while, we'll use it as an adjunct to help localize or improve our visualization. The next is thermal therapy. So we have bipolar probes. We have the coagulation grasp of forceps I showed you, argon plasma coagulation, snare tape soft coagulation. Then you have mechanical therapy over the scope clips, through the scope clips. We have suturing, and we have hemostatic sprays that are available. So our tool bag, even since I was a fellow 6-7 years ago, has now enormously improved, where majority of non-variceal upper GI bleedings in 2026 we can manage. So what is the best tool to use? Really depends on the situation, because the ACG guidelines will recommend that any of these tools are available and can be used for hemostasis that I'm going to go over. So let's start the first. You see a little bleeding. Still, the most valuable tool that we have is a regular through the scope clip, but you need to be able to know how to use it and use it effectively. So here's a visible vessel. So what you'll see is that once you get closer to the vessel, you don't just close and deploy at the same time. You close the clip, and then you take a breather, and you make sure that you have it where you have it. So you put water on it, and you make sure that there's no active ongoing bleeding. If you feel like your clip is causing true mechanical compression of the vessel, then you deploy it. So it's a three-phase process. You open, you close, you make sure it looks good, and then you deploy the clip. And here you'll see the clips deployed, and you get hemostasis. Sometimes, clipping may not work because it's really fibrosis, clip's not going to hold. So you need cautery. So this is gold probe. We all know how to use it. But what's really important to remember about gold probe is, like in this case, how they started off using the gold probe is not the right way to use it. The gold probe is the hemostasis occurs from where the gold is. So it's coaptive coagulation. You have to compress the vessel. And what's really important is if you're treating a vessel in the duodenum, you have a 7 French gold probe, and then you have a 10 French gold probe. So the 7 French gold probe is not a good idea if you're treating a vessel that's bigger than the gold probe. So you need to switch to a therapeutic upper scope and use a 10 French gold probe. So you're really putting mechanical pressure on it. So it's coaptive coagulation. So right now, all we've done is basically use it like an ABC catheter, haven't really tried to coapt and pressure on the gold probe. So you have to actually press on the vessel an uncomfortable amount, especially if it's a deep ulcer. There's always a concern that you perforate, but if you decide that that's the tool you have to use, you really have to go at it aggressively. So what happens if you just try to touch it or flirt with a vessel without really causing the coaptive coagulation? Then it starts bleeding because you haven't put enough pressure on it. So once you start bleeding, and like in this situation, then over the scope clips are a great tool that we can use for this reason. Once bleeding is started, it's the over the scope clip allows you really good mechanical ability to coagulate. And anyone who can use a bander can use an over the scope clip. So you'll see here that in this case, you put it over the scope. You want to make sure you take your time, and you don't want to just do a lot of test suctions because you can make the bleeding worse. So you want to make sure you're around it. You want to make sure that you're fully around the vessel. Take your time, suction. You want to suction really good. And then you want to deploy. And I tell the fellows to over deploy to almost when you break the deployment mechanism, because in the bander device, there's multiple bands you can fire. Over here is only one clip. So you want to over deploy it because when there's a loop in the scope, sometimes the clip will not fully deploy. So you really want to crank the handle till you make sure you get it. So here's another case of a non-bleeding visible vessel that here I'm doing, and you'll see that there is ongoing bleeding when you're there. You want to take your time, get yourself around it. Once you're confidently around the vessel, then you suction. And once you suction, you give it enough time. Don't be in a rush to deploy the clip. Sometimes I'll have our nurses request them to hold my scope, so because I need my right hand free to deploy it. So you're keeping a little forward tension on the scope, and then you deploy the clip and you get hemostasis. So what is the data that shows for over the scope clips? So over the scope clips, this was the first randomized control trial that was done in 2018, almost 8 years ago. We've had them. What it looked at for refractory bleeding. And you can see if you use standard therapy or refractory versus over the scope clip, the chances of recurrent bleeding are significantly less if you use an over the scope clip as compared to standard therapy. But the question then really comes is, do we use it as first-line therapy? So this is randomized control level 1 data that you can use over the scope clips as a first-line therapy, and the chances of rebleeding are much less. So the cost is much better because the risk of rebleeding and then patient coming back to the hospital and needing another transfusion, endoscopy, resource utilization is much higher. So you're actually doing a better job at cost by using an over-the-scope clip upfront for a non-variceal upper GI bleeding. This is another meta-analysis that shows for all randomized control trials that over-the-scope clip can be used first line for non-variceal upper GI bleeding. But sometimes when you do over-the-scope clip, bleeding still doesn't stop. So this is a case that I did over-the-scope clip, went perfect, and you can still see the spurting bleeding going on even after using an over-the-scope clip. So then what do? Is that the maximal therapy we've accomplished? So when you've had it over the scope clip, you've compressed majority of the vessel. But it basically means that you're dealing with a big artery that's feeding off of one of the major vessels. So in that case, you can use other hemostatic therapies. In this case, I used a coagulation grasper forceps. The vessel is partially compressed. Grab the coag grasper or hemostatic forceps, and then you'll see here that I was just with the 2 taps, I was able to control hemostasis. Coagulation grasper forceps, Dr. Clem just used them recently, last week. We'll tell you more about it, but they're a really effective tool to use for sometimes if you can isolate the bleeding. So this is a resection I did, and during my resection, all of a sudden bleeding occurs. When bleeding occurs, the first thing you do is you record so that you can show it in your talk. So then after you hit record, then you can now start thinking about how you're going to manage the bleeding. So now once you get the vessel on, you grab it. The benefit of this device is it gives you both thermal and mechanical feedback. So here you can see that when I first grabbed it, it didn't stop bleeding. So it means that I'm not actually on the vessel. So it's just like a biopsy forceps. Your nurse or assistant will open and close it. Once we get the vessel, now you can see I've already gotten hemostasis. Now I tent back so that the cautery is not hitting the muscle. And then you just press on the coagulation pedal, and then you'll get hemostasis. This, as you can see here, once we isolate this vessel, is a big vessel. You can see that this is an artery. So once you grab it, I tent back, all of a sudden bleeding stopped, and then I just put a blue pedal, making sure coagulation, tenting it away, and then you get hemostasis. So again, these things can look very stressful, but if you can visualize, my first principle, and then second, know what's in your toolbox, you can manage most of these bleedings. So the next is hemostatic sprays. Hemostatic sprays have been around now for 5-6 years and have been an amazing intervention for us. Initially, we thought they only last for a few hours, and so there's no point in using them. But there is data to show that even if you use them as first-line therapy, a lot of patients will not have rebleeding. So hemostatic sprays, here you can see this is a duodenal cancer that's bleeding, and this is one of our former GI fellows, Dr. Torres, who graduated, is doing this case with me on a weekend. And once you push the catheter out, you just have enough sprays. An important thing, these catheter clog. So we have 7 French catheters and 10 French catheters. 10 French catheters are less likely to clog, but you need a therapeutic upper scope to use a 10 French catheter. So important again to know what scope you're using, what tools you're using, and why I'm asking for all these scopes when we're going to the ICU. So again, enough data in the fashion of randomized controlled trial especially for malignant bleeds. You can use them as a monotherapy, and the rebleeding risk significantly reduced. And these are trials that are published in Gastro, Annals of Internal Medicine, top-tier journals, and of course have made it in our guidelines. There's a wide variety of hemostatics powders that are available. I highly encourage you to go outside of the vendors and check those out. We have all these powders that are on display outside. Each of them have their unique features that are available for hemostatic sprays. Again, they're part of our guideline recommendations to use them, especially for malignant bleeding, refractory ulcer bleeding when we cannot. So when you've used all that, the nice thing about us is that the toolbox continues to expand. This was one of the first case of malignant gastric cancer-related suturing that was published that I did for a patient who was in 4 pressors in the ICU, bleeding from a malignant linitis elastica, and we sutured it. And you can see here that this is a follow-up endoscopy to 4 weeks, and the ulcer is completely healed. The patient went on to live 3 months extra, and that was a very valuable time for them and their family. This is another tool that we have. This is a case that we published of using cryotherapy for ulcer bleeding. Again, check it out outside if they haven't had a chance to look at some of these technologies. So this is diffuse bleeding, very hard to treat because they're bleeding from everywhere, and the patient is needing transfusions, repeated hospitalizations, and there's really you can't clip all these vessels, you can't burn all these vessels. So cryotherapy uses freezing therapy to try to do that. We do offer it here at the University of Colorado. So once you put this uses liquid nitrogen spray. So we put a venting tube because nitrogen expands really quickly to make sure that we're venting all the gas, and it just freezes all those areas. And this patient, was finally able to be discharged after using, needing 9 units of transfusion over multiple endoscopies that we're able to do. So this right here is a big vessel, right? So you've seen this talk and you're ready to tackle every single bleeder that comes your way. So you see this vessel. This is one of my colleagues from Europe who's kindly shared this video with me. When you see this vessel, you grab it with a coag grasper, you've listened to me talk, and then this starts happening. So rule of thumb, if your vessel is bigger than your device, it's not going to work. So in this case, they shouldn't have used a coagulation grasp or forceps. Patient ended up needing emergent IR embolization. So the last point I'll make is the endoscopy has come a long way and we can do a lot, but it's remembered that there are still certain limits where we need a great relationship with our IR and surgery colleagues because they will be the ones who will bail us out. So in this case, patient needed IR and surgery. So one of the reasons of developing proficiency and skills is knowing when not to intervene and when to stop. So this was a case where we should have not intervened and patient needed intervention radiology. So in summary, this is the AGA algorithm that goes over managing non-variceal upper GI bleeding, talks about all the things I've talked about, starting with normal therapy, and everything fails, you go over the scope clip or hemostatic sprays. And in summary, to be respectful of time, the take-home points, you can't see what you can't treat what you cannot see. So it's important to visualize the source of bleeding. So remember pre-procedure prokinetic if patient is actively bleeding. Sedation plan. If they're actively bleeding, they need to have a breathing tube in. Otherwise, patient will be vomiting and they have a high risk for aspiration. Think about that, especially when dealing with variceal bleeds as well. If you're dealing with a big bleeder, think about a scope with a bigger working channel or diameter, so a therapeutic scope, because they have a larger working channel, allows for better suction, but also allows for better tools, the 10 French catheters and tools that can be used. A clear distal attachment cap is key, especially in tough locations near the G junction or the D1, D2 turn, where it helps flatten those folds. The best treatment modality is the one that works, but it's important for you to know the toolbox and know your backup options. Don't try the same thing again. If you can't manage it, ask for help. We're blessed to be in an institution where we always have help around and we can ask each other for these questions. And sometimes setting to IR surgery is the best option. So thank you so much for your attention.
Thank you so much, Dr. Bilal. Despite it being afternoon and not 2 a.m. with a new fellow, heart rate's definitely still up after that.